Hi everybody, this is Lavanya Kandapalli. I'm with Dr. Joseph Carver. We're really excited to go over our case with you, a case that we actually saw just a few months ago here at Penn. So the subtitle of our case today is Don't Judge a Book by Its Cover, which interestingly comes from George Eliot's The Mill on the Floss. And for those of you who may or may not know, George Eliot is actually the pen name for Mary Ann Evans. So it's kind of ironic that she included this phrase in her book. So in terms of the patient that we're going to talk about today, this patient initially presented to oncology here at Penn for a second opinion in August of 2013. Her history is that she's a 75-year-old female. She has T2N1 ER/PR positive, HER2 negative left breast cancer. And she came in August for a second opinion regarding new liver metastasis. And her history was that she was initially diagnosed with breast cancer in 2011, T2N1 ER/PR positive, HER2 negative. In July of 2011, she underwent a left lumpectomy. She also had a left sentinel node biopsy and axillary dissection at that time. She then completed 4 cycles of AC. And she also completed radiation to the left breast, the supraclavicular region, and the axillary regions. And then up until the present time, since about January of 2012, she was maintained on anastrozole. When she presented to oncology in August of 2013, she basically said that about 3 months, well, 3 months ago when she was on a cruise, she had noticed new shortness of breath and lower extremity swelling. She was in Germany at the time, and she had LFT strong, which were abnormal, and some imaging had revealed that she had had some liver lesions. When she returned to the United States by July of 2013, she underwent an FNA of the liver, which was notable for malignant cells consistent with metastatic adenocarcinoma. ER positive, PR negative, and the suggestion was that it was probably a breast primary. This is with regards to her past medical history, notable for a history of hypertension, hyperlipidemia. She had a history of PE, was on chronic anticoagulation, given that she had a prothrombin mutation. She was a remote smoker, otherwise had no family history of heart disease. And with regards to her medicines, was on a good regimen with atenolol, hydrochlorothiazide, and ramipril, pravastatin, and warfarin. So when she was seen in August of 2013, understandably, she was anxious to start therapy. On review of symptoms, she kind of noted that she had had new fatigue that kept her from usual exercise classes that she attended. She also had decreased appetite and started to feel nauseated. Her vital signs were unremarkable. She appeared very well. There was nothing that was particularly notable on her exam. And the oncologist, and at that time she had had noted just 1+ non-pitting lower extremity edema. So the oncologist reviewed multiple options with her and recommended that she stop Arimidex and consider chemotherapy. And then the patient then went back to her local oncologist to start chemotherapy again. She then returned to Penn just about 3 months later for interval follow-up in November of 2013. By this time, when she saw the oncologist, she had noted that she was really having progressive shortness of breath for months. She had new orthopnea, new P&D. The lower extremity edema that she had had 3 months earlier was now worse and persistent. And she'd also kind of noticed this new constant non-productive cough. By the time she was seen in November of 2013, she had completed 3 cycles of Abraxane locally. And a CAT scan done after her second cycle showed that the liver lesions were stable and she'd had no new metastatic disease. And this is from the oncologist's note when they first saw her, did a very thorough review of systems. And some of the pertinent positives was that she had had the fatigue, the cough, dyspnea, shortness of breath, orthopnea, P&D. On the GI review system, she had had diarrhea. And she had also had lower extremity edema. Interestingly, she did not have some of the neuropathy associated with Abraxane. And this, again, is the oncologist's physical examination, Her blood pressure is fine. She's satting normally on room air. She's still well appearing. Her lungs were clear on exam. However, they did note that her JVP now was about 12, and she had prominent pulsations in her JVP. Her liver was enlarged about 2 inches below the rib cage, and she by now had 1 to 2 plus pitting symmetric lower extremity edema that had now extended all the way to her knee. So at this point, we'll take a pause and be interested in hearing what the audience maybe thinks about what's on the differential diagnosis for this patient.
Yeah, so in summary, it's somebody who's been exposed to anthracyclines, subsequent chemotherapy, presents with on the surface what looks like heart failure with breast cancer and metastatic disease to the liver. No takers. Okay, we're going to go on.
Okay.
Oh, so she was actually, when she came back to Penn, she was referred to us for opinion about what is the differential diagnosis. And Lavanya will continue. Go ahead.
So the oncologist, of course, as all things go, this woman was like the last patient of the day, but luckily they were able to at least start the evaluation for us and were able to get an echocardiogram the same day. The read on the echocardiogram, that was, of course, the last read of the day as well, was that the EF was now about 40 to 45%. Her LV was kind of globally down. She had moderate AI, mild to moderate MR. Her atrium were slightly dilated on the right. Her RV was slightly dilated but normal function. And then they had noted that the mobility of all her 3 tricuspid leaflets was decreased and that she had new torrential tricuspid regurgitation. So we ended up seeing her, we found out about her after she had already left, and so we ended up seeing her the next day in cardiology clinic. And as all things go, Dr. Carver always makes us look at the primary data first. And so although she had had that echo read, before we actually saw her in the clinic room, we reviewed her echo ourselves.
Does anybody want to comment on the echo? See, so Dan, are you on? You can comment if you're there.
He actually hasn't joined in yet.
Yeah, we can't tell who's on because we're okay. All right, Lavanya, go ahead.
Okay, so this is a standard apical 4-chamber view of the heart. The left atrium and left ventricle, I'm not sure if you can see this pointer, left atrium, left ventricle, right atrium, right ventricle. And what's notable here is not only is the right atrium a bit dilated, but also you can see what they called on the read of having the tethered look to the tricuspid valve leaflets, and that the RV is a little bit dilated. If anyone can...
Stop. So I just want to comment that we looked at this, and Lavanya goes, she's got carcinoid.
Maybe some of you also would have identified that as well. But yeah, this is a very classic view right here of how the leaflets look in carcinoid heart disease.
So we walk in the room, and I say to her, we already knew about the diarrhea. I said, do you have any problem with flushing? And she goes, oh my God, my whole life, or at least for the last 5 years, that she has episodic classic flushing.
So here's a view. Here's a view again of the right atrium, a different view, but here with the color Doppler, you can see over the tricuspid valve. This is the torrential TR she has. So basically the blood just is continually moving back and forth over the valve. Not sure why. Okay. Now this is continuous wave over the tricuspid valve, and this is kind of a classic dagger shape when you have severe TR, that all the blood forward also goes back right away. All consistent with severe TR. And this is actually a view of the pulmonary valve, the pulmonic valve, again the flow over the pulmonic valve. And again, you can see that she has severe pulmonary regurgitation, again reflecting the fact that the carcinoid has affected the right-sided valves of her heart. And just as Dr. Carver said, that when we talked to her, she had said that she had had long-standing diarrhea and also facial flushing. And in terms of what we did on short order is we started to try to manage her right heart failure and initiated the evaluation for carcinoid. Here are the values that we received back. So for her urine, her 5-H1AA, it was 439. In our lab, the upper limit, if it's 10 times the upper limit of normal, which in this case would have been 140, they say it's highly consistent with carcinoid. Her serum chromatographin was also extremely elevated, as was her serum serotonin. And then we were in touch with our oncologist and had her initial liver biopsy from July of 2013 reevaluated. If you remember, that biopsy was initially read in this patient as being consistent with a breast primary. However, when they did additional staining, it was positive for some of the neuroendocrine markers, and the overall diagnosis was then changed to an intermediate grade neuroendocrine tumor. And now, taking everything together, her new diagnosis is now a 75-year-old woman with a history of breast cancer who has carcinoid tumor in the liver, and she was initiated on treatment with octreotide. So just briefly about carcinoid heart disease. In terms of kind of where we stand with carcinoid in general, the incidence of carcinoid is extremely low, so 1.2 to 2 out of 100,000 people. Of those few people who actually get neuroendocrine tumors, about 50% will actually then develop carcinoid syndrome, and even a smaller percentage, so about 20 to 50% of the 50 with carcinoid syndrome go on to develop carcinoid heart disease. What's interesting about carcinoid heart disease is that that's actually considered the initial presentation of carcinoid in 20% of patients, just like in our patient. And what's really classic for it is that you develop this plaque-like fibrosis that deposits on the endocardium and it likes to go to the valves. They've also found it within the endocardium of the right side of the heart. And that plaque develops because of the release of vasoactive substances in carcinoid. And to your right, you can see an image of the tricuspid valve that has been surgically removed in a patient with carcinoid. And then there's deposits on the right side of the valves, the right atrium, the right ventricle. And really the left-sided involvement is pretty rare. It usually happens in patients with PFOs, tend to get left-sided involvement. Or if you've then unfortunately developed involvement of your lung, those patients will then have left-sided carcinoid heart disease. In terms of the survival, in general, for well-differentiated neuroendocrine tumors, one study looked and said the median survival is about 124 months. Unfortunately, once you've gotten diagnosed with concomitant carcinoid heart disease, the median survival decreases to about a third of that at 48 months. And then unfortunately, if you also have class 3 or 4 heart failure, the median survival is about 11 months. Although there are not many patients with carcinoid heart disease, it has been shown in small studies that age and also severe TR are independent risk factors for death. And the most common cause of death in this patient population is right-sided heart failure. So something that unfortunately our patient is at high risk for. And this was an interesting study actually of 200 patients from the Mayo Clinic, of course, who had carcinoid heart disease. And what they looked at is they looked at the kind of their experience over about 20 plus years. And what's really notable is that unfortunately there are certain features that decrease your survival. So if you have moderate to severe RV dilatation, the survival at 10 years is less than 20% by, but even at 4 years, the survival is about 20%. Those with NYHA 3 or 4 heart failure, again, by 4 years, the survival is 20%. And also now, in the last 10 years, people are sending patients to surgery for right-sided failure, for tricuspid valve replacement, also for pulmonic valve replacement. And survival, if you can survive the surgery, your overall survival is better. However, there's no clear guidelines on who should be recommended for surgery and at what time point. Unfortunately for our patient, she's pretty ill, and so surgery for her would not be something that I think is going to necessarily impact her survival a ton. That's it.
So any questions or comments?
Yeah, hi. Diamond, can you hear me?
Yes, hello.
Hi, I'm a nurse at the National Cancer Institute. Sorry, I think I'm echoing.
No, that's good. You're coming out okay.
I'm not a cardiologist at all by any means, and I'm curious. So, is it likely that this was in existence prior to her initial treatment?
Yeah, probably. My guess is it's been long-standing. I mean, she's had flushing and diarrhea for more than 5 years, so this has probably been around for a while. And I think that the sort of going experience with neuroendocrine tumors in general are that that the average time to make a diagnosis is like between 5 and 10 years.
Got it.
And people have disease for a long time, and they go from place to place till it gets to a point that the diagnosis is made.
These sessions are so interesting, and I really appreciate you taking the time to present today, and I'm learning so much every time I listen. But one of the things we're doing here at NCI is we've pulled together cardiologists and oncologists in terms of researchers and looking at some of the issues around the cardiotoxicity from chemo. And one of the things we're talking about right now is baseline risk assessment for patients and the lack of consensus around how we look at patients, what we ask, what assessments we make prior to starting chemo. And, this just highlights this issue of, a really deep, good cardiovascular assessment prior to putting patients on these treatments, especially in older patients. And what are we doing and what are we not doing, and what should we be doing? So I just want to share that. That's what some of the dialogue that's going on right now.
Well, so we don't have to be convinced about the cooperation between the two specialties. I think that we both, however, still tend to be focused on our organ. And that this is just to remind everybody that everything on the surface, everything isn't what it appears to be, and that I still go back to the beginning of time, that you have to look at everything and not read reports and not believe what you hear from other people. So.
Right.
And so this lady did get 3 cycles of Abraxane, which she may not need it. At least we know that carcinoid doesn't. It's an uncontrolled trial that Abraxane doesn't have any value in carcinoid.
Right.
And interesting, probably AC doesn't either, since she probably got chemotherapy when she had carcinoid. And I think that over the years I've seen 2 or 3 people with late diagnosed neuroendocrine tumors who have gotten chemotherapy that doesn't work.
Right. Well, thank you again.
But again, I mean, so Lavanya, she looked at one frame and within like 10 seconds said, this looks like carcinoid. And then we went in the room and asked, two questions, and it was consistent. And then the rest was all like, oh my God, we have to get some, we have to prove this now.
Right.
She did have classic TR findings, the big V waves, and her liver was pulsatile, and she had really a lot of edema. And she's unfortunately continued in spite of our efforts to retain fluid, and she has a rapid devolutionary course. She would have been better off having metastatic breast cancer to her liver than to have what she has right now.
Yeah, definitely. And you're right, it just underscores the need for expanding our thinking about how we look at these patients in terms of, I think, our assessment and, the fundamental assessment and the cooperation between the two specialties. Absolutely.
Yes.
Does anybody else have any comments on this case? So is there a differential diagnosis of severe tricuspid regurgitation that you'd like to go through as an isolated finding, isolated tricuspid regurgitation with normal right-sided pressures?
Yeah, so carcinoid, people, big RV infarction, pulmonary hypertension, so the people with pulmonary hypertension.
Right.
I was thinking if you could give a differential without pulmonary hypertension, what would your differential be?
Well, so probably the most common thing, depending if you're in a city environment, is drug use and right-sided endocarditis. Is probably the most severe tricuspid regurgitation I've seen. And actually, I've seen one person with with ovarian carcinoma. There's a subset, a mucinoid cell type of ovarian carcinoma that has neuroendocrine features, and that the person I saw presented with tricuspid regurgitation.
Right, and that happens because it doesn't go through the
Right.
drainage doesn't go to the liver, so you can have ovarian.
So it's an ovarian tumor, not it's not carcinoid, but it has carcinoid-like features. And I think it's actually like a clear cell ovarian tumor. It's kind of rare. I don't know.
Other than that,
TR.
damage from
Congenital
pacemaker lead,
Yeah.
causing TR.
Well, you never the TR that you see from pacemakers is generally is trivial and not hemodynamically significant.
So I guess some of the things that we've seen is I wrote with a group an article for Willis Hurst's book called Heart about traumatic tricuspid regurgitation and presented 19 cases. And basically it's someone who has trauma, but it really doesn't cause severe problems for like 20 years. And then you find this patient with severe tricuspid regurgitation, and you go back in the history and find that they are a steering wheel injury, or they got kicked by a cow, or near a grenade that went off in the military or something 20 years ago. And it's sort of a diagnosis by exclusion, and you always come up with a history of some trauma that was significant that occurred. And then we see a couple I guess in the course of your lifetime in cardiology, a couple adult, older people with Epstein's anomaly that has been undiagnosed their whole lives, and they come along at age 70, and you pick up on that. And so that's a couple of the funny ones that we've seen here. I guess pacer-induced tricuspid regurgitation, not due to the pacer wire, but due to the asymmetry of left ventricular conduction and contractility that leads to severe tricuspid regurgitation. You turn the pacer off, it goes away. You turn the pacer on, it comes back again.
This is Greg Emery. One that we seen do a lot of the RP is instead of a cord or a capillary muscle from the bioptome and iatrogenic. And there are more that we biopsy, the high risk of this is something that I wouldn't harm, but in that population, certainly they're at risk.
Any other comments from anybody?
So I have another one. So.
Oh, great.
Metastatic melanoma, sarcoma of the heart that also involved the RV with severe TR. But these are all sort of isolated onesies.
Yeah, I guess we see that also with right atrial masses, patients who have right atrial myxoma and invasive right atrial masses. And we see quite a few of those kind of things from the MD Anderson Cardio-Oncology Tumor Conference when they present cardiac tumors once a month. There's a conference with Vanderbilt, Michigan, us, and MD Anderson. It's a very interesting conference.
So, because of the ubiquity of ports that we see, port at the end of the catheter tip thrombus, sometimes pretty large, that occludes the tricuspid valve, or that at least messes up the anatomy, and you get TR and TS, but not torrential like this. We always neglect the right side for some reason. Anybody else?
Angela, do you have any comments from Moffitt?
Mark, I would say that we don't see a lot of people in Philadelphia who get kicked by cows.
Maybe Chicago. Mrs. What's-Her-Name's cow. Well, we've perhaps that's more of a country diagnosis, but here in Florida we collected like 19 cases and presented them in Dr. Hurst is one of his books.
Nice.
So I think that sort of wraps it up. So that's a great case, and we've got a recording of it, which we'll post. And we really appreciate you presenting that case from University of Pennsylvania. Thank you so much, all of you.
Thanks for letting us do it. It was fun.
Yeah, we had a great time, and I look forward to seeing you next month. Thank you so much.
Okay, bye-bye.
Bye-bye, everybody.
Bye-bye.
Bye, Greg. Bye, Eileen.
Bye. Bye, Eric. Thanks so much.
Yeah, thank you so much.
See you later.
Yep, take care. Bye, Angela.
Bye-bye.
Yeah.